All right, so this is kind of my screening I would do for someone that I would suspect to have a right partial rotator cuff tear. So first with palpation, I would always check the unaffected side just to see like what we're working with. So with the shoulder complex, we know it's this bundle right here. So first I would walk up the scapular spine. Any pain there?
No, not really.
Nope. Okay, moving into the acromion. Any pain here?
Not too bad.
Okay. And then from the acromion angle, dropping down onto that greater tube. And then just palpating, just passively, internally, externally rotating, feeling for the biceps tendon. There it is. And if I come off that, a bit down, coracoid process right here. And following the clavicle, immediately SC joint, and then also palpating for the AC joint. So right here, any pain there?
Not too bad, no.
Okay. Then the same process on the affected side. So along the scapular spine, any pain here? Okay. Then to the acromion, pain here? Any pain on the, and then also I palpate the supraspinatus tendon, which is right here. And then also again, look for that biceps tendon in the groove. There she is. And again, coracoid process down here, and then fall along the clavicle. And then just a quick screen for bilateral shoulder flexions. Just bring it up. Any pain on here?
A little bit.
A little bit. And then I would take my goni measurement. Acromion as the fulcrum. There she is. Trunk bisecting onto the trunk bisecting stationary arm, movable arm of the shaft of the humerus. I got about 121 there. And then while I'm here, we'll do quick MMT. Don't let me move you either way. 4+ on the right or left, 4- on the right. Then thumb out to the side. Straight up. That's screen's normal. And then for quick screen of acromion, bisecting the trunk, shaft of the humerus, we're getting about 136. And then out to the sides for quick abduction MMT. Don't let me move you. Again, probably 5 on the left, 4 on the right. And then just a quick internal external rotation. Go ahead. For external, go ahead and put your head behind your back. Okay, go ahead and relax. I think right here is roughly C4. And then go ahead and do it with the left. Or point on the, and then this is internal rotation. Go ahead and relax. About T8. Go ahead and do that with the opposite so I can get a quick baseline. Okay, go ahead and relax. Roughly T2 on the left for external rotation, internal, go ahead and relax. About T12 for left internal rotation. And then a quick way to screen for both internal, external rotation for MMT. Bring your arms to the side, don't let me move you. Say 4- on the right, and then 4 on the left. Don't let me move you out for internal rotation. And that's pretty bilateral at 4+, which is expected with a rotator cuff. Special tests we can do, first the empty can test. So bring your arms out about a 45-degree angle, thumbs up. Don't let me move you. Any of that cause pain? Okay, go ahead and do thumbs down. And any pain there?
Yeah.
And positive empty can test, that would indicate some sort of rotator cuff tear. Another test I could do is the Hawkins test. Another way just to rule out any shoulder injuries, so bring it in. Any pain here?
A little bit there.
And then as I go in more and more. So that's just rule something out, but another one we could do specifically for the rotator cuff is the drop arm. So bring it up. I'm gonna remove my hands. I want to try to keep it up, okay?
Okay.
And if it drops down like that, that's positive drop arm. Pretty indicative of a rotator cuff tear. Next, I'm going to do some PROM and some joint mobility, so go ahead and lie on your back with your head facing this way. And then just for the passive flexion, bring him up. Let me know if there's any pain anywhere.
A little bit.
A little bit right there. So I would have him hold that position. Again, same idea. Bisect the trunk, the acromion roughly. Looking at about 170. And then bring him up and out for abduction. Right there.
Mm-hmm.
Same idea with AROM. Okay, you're getting about 155 off a glance. And for internal rotation, stabilize at the chest. And just bring it in. A little up. Right there, roughly. So fulcrum is elbow. Stationary arms perpendicular to the ground. We're getting about 35 internal, and then external just the opposite way. This would be expected to be limited in a rotator cuff injury. We know when. Right there. So I have hold that there. And roughly about 60 degrees. So then some joint mobility stuff we can do. Quick posterior glide. Just nice support around the arm. Little distraction, push down, check for that joint feel. Say that's pretty normal. Maybe a little hypomobile. And an inferior glide, just turn around. Give a good push forward. And check for that. That's pretty normal. And then moving right into a grade 4, small amplitudes up through tissue resistance. So pushing through, feeling that resistance, staying there, giving them nice little oscillations. How's that feeling?
Yeah.
Okay.
Yeah.
And then just kind of the mechanism of impingement turning into a rotator cuff tear. Impingement usually starts with just overuse of that rotator cuff muscle, and then as you use it more and more, you tend to get micro traumas, and as those micro traumas build, you get macro traumas, and as that builds, eventually becomes a rotator cuff tear. And that's my screening for a suspected right partial rotator cuff tear.